Now I would like to introduce Dr. Hendrik Fowler. Will present the Facing a Triple Vessel Nightmare lesson from my worst day in the lab. Please.
Thank you very much. It's difficult to present after Eric. I saw this case twice, as you mentioned, and I was still shocked and amazed. I don't know, in a good way. So this is just a very basic PCI case, but I made multiple wrong decisions, and I hope I can find some teaching points for you guys. How can I advance the slides? Oh yeah, okay. So this is a 83-year-old female patient with a chest discomfort on exertion within the last couple of months. She had multiple comorbidities like diabetes, hypertension, hyperlipidemia, moderate kidney disease, and had a COPD. Echo and EKG were unremarkable, and given the very high likelihood of the presence of a CID, we took her straight to the lab. So this is the diagnostics. Okay. This should, so you shouldn't see the PC there. Okay. I need to explain what you're seeing. So this is osteal RCA disease, high-grade stenosis in the mid LED with a large diagonal. I hope this will. Okay, and very tight stenosis and osteal circ and proximal circ. I'm really sorry for this. Worked on my computer quite well. So we had a hard team discussion with the patient and with the surgeons, and she was turned on for surgery, given her comorbidities and advanced age. So I planned a complete revasc of the left system and a stage PCI of the RCA. I went maximal guide support, 8 French femoral. I thought about putting in an impeller, but given the preserved EF, I did not. So I started with the circ. I'm really sorry, the images are really stretched in a weird way, so I hope you can see a little bit. So I wired the circ with a polymer jacketed wire, but I could not cross with the MC, with a microcatheter, which was the Crosser Pro. What I usually do then, I bury the microcatheter in the lesion and try to direct wire with a rotor wire, which was possible in this case. Sometimes I cut the radiopaque portion of the wire, at least 2/3 of it, to facilitate wiring, and I start burring. I choose the big burr. This was a 2.0 burr. I wanted to be maximal efficient here, and I made very little to none progress. So I was in that case for 3 minutes ablation time already. And then the patient complained with severe chest pain. So I took a picture, and as you can see here, I had a no reflow. The circ completely shut down, and it's low to no reflow in the LED. So I was pretty surprised with that, and I called for medication, which was not mixed on the table. So it took me a minute, and I administered drugs through the guiding catheter. This is my cocktail here, epi and adenosine and multiple boluses. And at least I restored flow on the LED, but the circ was still shut down. Given the fact that I never lost wire position, and I was quite convinced that this was not a flow limiting dissection, I downsized the burr to 1.25 and started ablation, and I crossed the lesion quite easily and restored flow in the circ. What I did then, I went straight for rotor ablation of the LED because I was set up for rotor and had everything on the table, which was a major mistake. So I wired the LED, the rotor wire, it was quite easy. Started rotational atherectomy. I used the same burr that I used for 3 minutes already, high-speed ablation. And yeah, well, but I didn't make any progress in this case. So patient again had chest pain, and by that time her blood pressure dropped significantly, and we needed to place her on inotropes and vasopressors. So you can see here in this first picture, now the LED shut down. So I gave another round of medication through the guide and restored flow to a TIMI-1 flow in the LED, and downsized the burr again to 1.25. And easily crossed the lesion. But at that time, the patient felt worse than before. Her blood pressure dropped. I needed to increase the inotropes and vasopressors, and you can appreciate here, now the circ shut down. I gave more medication for no reflow here, wired the circ. I lost a bit of time there, and then the patient completely crushed. As you can appreciate here, I had stasis in the coronaries and really morbid backflow in the aorta, which is a sign of a dying heart. So by now, the patient was in severe cardiogenic shock, developed complete AV block as well. And this was actually the first time I called for help. I placed a temporary pacemaker and set up for the impeller. But we had very difficult groin access. So by the time I placed the impeller wire in the LV, the patient arrested due to VFib. You're not able to see this. It's not my fault. Sorry. So this is us performing CPR here. I'm sorry, guys. I'm just telling you what I'm doing here. So after a short round of CPR and one in shock, I placed the impeller, quite challenging, giving the groin access, a lot of calcium. After having the impeller in place, we wired the LED to put in a stent, but the LV was already too ischemic for such a long time, and the patient arrested again. We were now using a mechanical CPR device, shocked the patient, and this went over and over again. I have to tell you by now that we are not an ECMO center. We are 1 hour away from the next center, and this would take too much time to activate a team there. So I stand at the mid portion of the LED. I had a fine result here and went straight for the circ, put in a stent and a proximal circ, and this was the angiographic result. I don't know if you can see anything here, but all arteries were open, TIMI-3 flow. What a great result here, right? But the LV was too ischemic for such a long time, so the patient arrested again. Now it was a PEA arrest. We ruled out tamponade a couple of times. By that time, the patient was intubated and on sky-high doses of inotropes and vasopressors. So after half an hour of CPR, giving the advanced age, we stopped, and the patient deceased on the table, which was quite frustrating and upsetting for me. I then unscrubbed and did the last echo myself, and by that time the percutaneous emphysema was obvious. So the patient, yeah, maybe you can appreciate here, this is a huge tension pneumothorax after a prolonged CPR. So I didn't expect that. I placed the chest tube right away, but we were not able to rescue that patient. She went on minimal care to the ICU and deceased the same day. So first of all, very sorry for this horrible pictures. I mean, the quality. I want to talk about a few lessons I learned from this case. It was a few years after fellowship, I was somehow overconfident and not thinking wisely. So let's talk about how to choose the right burr size. We usually go big with a ratio burr size to distal vessel diameter 0.6 to 0.7 to be efficient. But if you have a very tight stenosis, like in this case, you need to downgrade the burr. Otherwise, the larger the burr, the larger the debris you will create, which will cause microcirculation obstruction, which causes slow flow and no reflow, as you were able to see in this case. Lesson number 2 is, I don't know if you're familiar with that, the rotor burrs wear out. They lose the crowns, the diamonds on the crown, I mean. They have a lifespan about 3 to 5 minutes ablation time. So if you see this, you already have a problem, most probably. So change the burr ahead of time. And what we do as well, we usually change the rotor wire as well to prevent wire fracture. Because if you have prolonged lesion contact on a specific point of the rotor wire, it is prone to fracture. Otherwise, you need to significantly move the wire to prevent wire fracture. As well, we were not very well prepared here with no reflow. I mean, if you use rotor and use big burrs, this is a possible complication. So pre-mix medication before dealing with the cage with large plug burden or calcium burden, because if the LV is ischemic for too long, is not forgiving. So you need to be fast. The good thing is no reflow is preventable. Pause between the runs, flush the system, and put the patient on potent DAPT, and then you most likely won't run into a problem like that. But if it occurs, it's better not to administer the medication through the guide. It needs to be delivered distally and selectively, for example, via a microcatheter, which is on the table already, or aspiration catheter, or whatever you want. Last lesson is rule out pneumothorax or tension pneumothorax after prolonged resuscitation. I don't think that this would have saved the patient, but yeah. So in conclusion, be prepared for possible complications, especially if you have a complex case. But if you run into a complication, you need to accept it first, fix it, and then stop the case and bring the patient back. I should have never gone straight for the LED here. And this was certainly traumatizing for me for some time, but it's not only traumatizing for the first operator, also for the team. So debriefing is very important. Give yourself grace, stay humble, and share your complications to help others and yourself get better. Vulnerability isn't a weakness, it's a strength. So thank you very much and good luck.
Thank you so much, Hendrik, for sharing that fantastic case. And there are so many lessons to learn there. There are many technical lessons, but I think one thing that's not taught well in the softer science of complications is what you brought up exactly. How do you debrief the team? Because, under those circumstances, the emotions run really, really high. People are angry, people are frustrated, and choosing the right time, understanding what to say, and understanding how to be effective to make sure that there are lessons learned that are not propagated, so the future essentially changes.
Absolutely.
It's not a skill that's actually taught in our interventional training. So many of us don't do it well. I've seen it done so poorly so many times. I think, once again, so many technical lessons, but I think that one is actually quite important. Yep.
Yeah, just before you, I want to invite Professor Nguyễn Quang Tuấn give your opinion. Yeah, please, you.
Yeah, I think it is very touch guy and very difficult. I agree about the regions. Yeah, the first thing I think that you choose the sign of the operator is the first mistake one. Is the first one because you cannot close the lesion by the microcatheter. Yeah. So it's very dry and very heavy calcification and also very tortuous. If you use a larger, bigger burst, it's very dangerous.
Absolutely.
For me,
absolutely. I couldn't agree more. Yeah.
Thank you, Hendrik. I think this is a very great sharing. It's a real complication. You need some courage to share those real complication case, and then everyone has some inspiration. I think for this case, just some comments. Just share the experience. If you do observation in one vessel, in case any complication, no refill or whatever, don't touch the other vessel.
Yeah.
That's my painful story before. So unless you have impeller, then you can do observation on two sides. Otherwise, just one and go stage. Yeah. The second thing is for those suddenly no refill, it's so strange. In real story, for those elderly patients, we have some similar case, more than 80 very fragile case. For unknown reason, they will go to no refill. Maybe you done nothing wrong, but suddenly they will go no refill, slow flow, and the patient will collapse. That will happen in elderly during PCI. We have similar case, but I don't know the reason. Yeah, it's the time. The time come. Yeah.
Dr. Takashi, do you have any comments from Japan?
Yeah, thank you for very nice cases. So our own experience is very limited. So we can learn this kind of session. So we know this kind of things happen. So it's very educational. And sometimes we just focus on just coronary angiogram. But like this case, we sometimes see the other hemorrhage, like not the access side, but like pneumothorax. So yeah, we can learn this case. Thank you very much. Yeah.
Thank you.
Yeah, thank you very much. Yeah, for me, the most important. Yeah, for me, the important lesson is how to know to stop at time. Yeah, because it's very important. We are very sorry of the complication, but when we see the complication and patient still alive, we should know how to stop, the time to stop to do give the patient come back